We have recently reported updates from FibroGen tonight, where Dr. Elman Kabadi will present data from his phase 2 trial on pamrevlumab. I can never say that right. Forgiveness, Dr. Elman Kabadi. Turning it over to you now.
Thank you, Ryan and Eric, for inviting FibroGen and PPMD community actually for inviting FibroGen to present their this breaking news for phase 2 results. That we decided internally that the first persons or committee to hear about it is PPMD, to show our appreciation to your community and to your organization. So without further ado, Bassem Mankabadi, I'm a board certified surgeon by training. I did my training back in New York at SUNY Downstate internship, then followed by Brooklyn Hospital general surgeon. Joined UCLA for a couple of years. Then I joined Amgen Oncology for 5 years. Then here I am leading the Duchenne muscular dystrophy program since 3 years here in FibroGen. Without further ado, let's dive in. Next slide, please. And today I'm going to show the disclaimer for our presentation, and as we said, we're going to discuss the phase 2 results in non-ambulatory patients. And then I'm going to give a overall high-level summary and conclusion for my presentation. So next slide, please. So this is a disclaimer. So in a nutshell, we have two categories here to compare our results against. The first one is a synergy data, which done against matched populations, so exactly matched patients with our trials. The other category is the published data that we have it in natural history, a bunch of papers with regards to non-ambulatory Duchenne muscular dystrophy patients, and we compared against our results that we had from in phase 2. In pamrevlumab infusion, after pamrevlumab infusion. Next slide. So next slide. This is, I'm going to talk about the main and OLE trial. So technically, this is the phase 2 study is started in non-ambulatory patients. We have 2 years data right now to announce or to publish with your community, and we're working on a publication anyway. It's an open label single arm study in non-ambulatory patient with Duchenne. Total 21 patients enrolled in this trial. Each subject received pamrevlumab at 35 milligram per kilogram biweekly for a minimum of 2 years of infusion. Subject rolled over into open label extension, which pamrevlumab will be given for additional 4 years or the drug got approved. Safety was assessed by a bunch of labs and physical examination. Respiratory function was evaluated by using forced vital capacity as a primary endpoint in this trial. Cardiac fibrosis was evaluated by ejection fraction measured by cardiac MRI. In addition to cardiac fibrosis was also evaluated by late gadolinium enhancement. Muscle function was evaluated assessing by performance of the upper limb version 2. And also we looked at the muscle fibrosis by mainly the biceps brachii muscle by MRI. In addition to the grip strengths by handheld myometry. The 2 years data that was analyzed, and the study was logged during the summer last year. And the 2 years data we'll present it right now. So this is just a schema for the trial, and showing that the trial is screening for 4 months, for 4 weeks, and then that main study, and then the data, the analysis that we had after 2 years, and then patients right now as they are in open label extension, and then follow up for 6 weeks after the last dose of infusion. Next slide, please. So this is just showing that the design of the trial before we dive into the data. So technically, without going into details here, so it's the primary endpoint is forced vital capacity by spirometry, and that the secondary endpoint were the forced expiratory volume at 1 second, and then a peak expiratory flow and MEP and MEP. Changes in the left ventricular ejection fraction from baseline to week 104, and then also the performance of the upper limb, the grip strength, and then the cardiac fibrosis by MRI, in addition to the biceps brachii muscle fibrosis. These are the main study. Next slide. And then this is the OLE. So we focused only on the result that showed some signal of efficacy, and we designed the OLE based on that. So the primary endpoint will be the forced vital capacity % predicted, the change, the annual change, and also we had another bucket, which is a performance assessment, will evaluate the pull, and then the handheld myometry, and then cardiac assessment will be the cardiac fibrosis, the ejection fraction by MRI, and also the myocardial circumferential strain by cardiac MRI. In addition to, of course, the safety assessment, which will be looking at all SAEs, NAEs, and any lab abnormalities in these trials. Next slide. All right, so this is the first category here. I'm going to talk about the muscle function. So what I meant by that is the performance of the upper limb, muscle MRI, and in addition to the correlation between the fat fraction and the muscle fibrosis by T2 mapping. Next slide. So the study 7, this is this table here showing a comparison between our trial, our pamrevlumab arm in performance of the upper limb versus Riccati paper, which showed 29 patients, and also versus Panay paper, which had 90 patients. So our trial was 21 patients, however, 19 only patients who did the performance of the upper limb. The age was similar, kind of. It's around 16 years of age in our trial, then 14 and a half in Riccati, and then 16 in Panay paper. The steroids usually in 100% in our trial, 82%, and then 57% in Panay paper. As you can see here, the performance, the baseline performance of the upper limb was around 24 and a half in our study, compared to the 50 in Riccati paper, and also in around 20 in Panay paper. So the change of baseline after 1 year and then after 2 years. So we will present the two data here, the 1 year and the two years data, to give you the overall view here. So as you can see here, the changes in baseline from baseline to after 1 year was declined by almost 2 points, and then versus around 4.13 in Riccati paper versus 2.5 in Panay paper. And then after 2 years, you can see that the trend is the same. We had decline of 4, and there was no data for 2 years in Riccati paper. However, in Panay paper, the decline was around 5.1. So you can see even that it's like that. The trend stayed the same across this trial. Next slide. And this is a diagram showing the performance of the upper limb versus Riccati paper. So pamrevlumab is in the green, in the blue color here, versus the green is Riccati paper. And then this is the first diagram here is the 1 year and then the 2 years. In study 079, as you can see, the pamrevlumab arm shows less decline than Riccati paper by almost half in the performance of the upper limb. Of course, as I mentioned, there was no data for 2 years to compare against. However, this is the result that we had for 2 years, after 2 years. Next slide. And okay, so this is Panay paper is very important paper actually to us, because it's showing the distal and the middle muscle in regards to the performance of the upper limb. So the first, the left diagram here showing the first part of the left diagram is the middle arm score. And you can see here that the pamrevlumab actually shows less decline than a Panay paper at the middle arm performance of the upper limb. And then also in terms of the distal arm, is same consistent result here. So pamrevlumab in blue is less decline than the green, which is Panay paper. After 2 years, the results showed the same trend. Pamrevlumab, actually the blue here, showed less decline in compared to Panay at both middle arm and the distal arm. Next slide. And I believe I have it in a table here. So showing exactly the same number and the same comparison here. So in a nutshell, while it's not controlled head-to-head comparison, less decline was observed for the key performance of the upper limb score in 079 trial, which is a phase 2 pamrevlumab trial, after the first and the second year of pamrevlumab infusion versus Ricotti and versus Panay paper at the middle arm and the distal, at the mid arm and the distal level. Next slide. All right, so upper arm muscle fat fraction by MRI, you can see that the mean change from baseline to the upper in the upper arm biceps brachii muscle fat fraction at 1 year in 8 patients was 1.8 compared to the mean increase in fibrosis by 3.2. So significant less fibrosis in the muscle with pamrevlumab arm compared to the Hoggerel paper that we compared against natural history data. In 2 years, the fibrosis only 2 years, we have only one subject. So this data is only for one subject. So it's showing the increase in fibrosis, however, it's just one patient. We'll focus only here about the 1 year, which showing the good results here. Next. All right, so biceps brachii muscle fibrosis T2 mapping by MRI. T2 mapping, it's of course it's showing the level of inflammation and edema and fat infiltration in the affected muscles, and this is proven by Magarath paper that I show here. In study 079, the mean T2 mapping score at baseline in 12 patients was +8. And the median was +7.5. The annual decline in biceps brachii muscle was around 2.1 gram. At 1 year, in 6 patients, there was a decline in the muscle, in the fibrosis changes in the muscles by 2.6. In pamrevlumab arm, showing in the green here in the left diagram, compared to a Hoggerel paper that showed like more fibrosis in the muscles. After 2 years, same trend, you can see that fibrosis stayed almost the same after 2 years. Next slide. And this is a correlation showing that's a scatter plot showing a correlation between the changes in the fat fraction within the biceps brachii muscles versus the change in the performance of the upper limb. So the bottom line that I'm trying to say, what that mean? All this less decline, less fibrosis changes, does it impact the performance of the upper limb or not? Interestingly, that there was some promising and positive correlation. So the less fibrosis changes in the muscle, the better performance of the upper limb. So next slide. And then this is, as I mentioned, that synergy, we had synergy data as well, which is the identical patient, kind of very matched population between our synergy data and our trial. So the main age, this is in terms of the grip strengths. Age, as you can see here, is around 16 in our trial versus 14.5 in synergy data. Corticosteroid was almost in 100% in both in pamrevlumab and synergy. Grip at baseline was 45 versus synergy was around 13. Change in baseline from the grip strengths was in plus. In pamrevlumab arm 1 point in 19 patients. And in the dominant hand. In the non-dominant hand, actually improved by 1.86 also in 19 patients. Versus synergy. Synergy showed decline by almost half point at after 1 year. There was no data for 2 years at synergy. And again, the changes in after 2 years was almost 2.5 in 3 patients only. and in the dominant hand, and then this is the non-dominant hand. And again, was a little bit better, actually worse. This one is worse than Synergy. However, it's only 3 patients. Next slide. And this is a diagram showing the muscle function in grip strength in a diagram fashion here. So the blue is pamrevlumab, and we compare it against Ceferian, which is the green bar here. So, and then we compared it also against Ricotti paper that I just mentioned earlier with the pull and pulmonary with the pull for now. And then the green, again, is the Ceferian paper, and then Synergy data is that dark blue. So as you can see here, pamrevlumab actually showed better results in the grip, actually better in positive 1 Newton after 1 year, and remain above all this data, all this natural history. So the Ceferian better than Ceferian, what they observed in their paper, and also better than Ricotti paper, and also better than Synergy in terms of the grip strength. Next slides. All right, so we talk about the muscle function. So let's change gear here and talk about the pulmonary function. What I meant by pulmonary function is the forced vital capacity, peak expiratory volume at 1 second, and peak expiratory flow. Next slide. I don't want to run out of time here, but I'm going to be very quick. Despite that, so this is a comparison between the Synergy data and in terms of the pulmonary function test and pamrevlumab after 1 year and 2 years. Again, Synergy data was matched population. So the age, as you can see, he's almost the same, 15 or 16 years of age in our trial versus 14 and a half. Corticosteroids was almost in both pamrevlumab and also with Synergy. The baseline forced vital capacity in our trial was around 54 versus 66 and a half in Synergy data. The change in baseline from baseline in forced vital capacity was -4 versus around -7 in Synergy data after 1 year. So it's almost less 50% better results, or yeah. And then the change at 2 years was -8 and versus -10.7 in forced vital capacity. And again, despite the lower forced vital capacity to start with, so we have the forced vital capacity was better at baseline in Synergy data. And despite that, despite the worst baseline, the forced vital capacity showed a little bit better result than Synergy data. Next slides. All right, so that's Synergy data. So let's, we also didn't stop here. So we compared it against Ricotti papers just to make sure that we're not missing anything here. So as you can see here, this is the 079, which is pamrevlumab arm versus Ricotti paper. As you can see here, the patients was around the same age group. 100% of our patients were in steroids versus Ricotti paper, only 82% were in steroids. Baseline percent predicted forced vital capacity was 54 and 62 in Ricotti. And then the change in from baseline and forced vital capacity was -4 versus -5.5, let's say. After 2 years, it was 8, and there was no data available for at 2 years at Ricotti paper. And then that's for forced vital capacity. Also here, I'm showing here in this table the peak expiratory flow, the same thing, where actually the results in pamrevlumab was almost 50% better than the result that observed in terms of the peak expiratory flow changes after 1 year in Ricotti paper. And also forced expiratory volume in 1 second, the same thing, actually almost half a better result, like 50% better than Ricotti paper, -4.5 in peak expiratory, forced expiratory volume at 1 second compared to Ricotti. And 2 years data showing -8 in forced expiratory volume at 1 second. So the trend of all the pulmonary function tests is the same. Pamrevlumab as a monoclonal antibodies is better than Ricotti paper here and compare with the 1 year data. Next slides. And this is a diagram to give you a feedback, like a feeling of what we had here. Pamrevlumab is in green, pamrevlumab is in blue, Ricotti is in green. And then we compare it against Mayer. In addition to Ricotti, we compare it against Mayer paper, which showing here in the gray, which is the placebo arm. And then Mayer, the same paper, has the glucocorticoids arm is in that burgundy color. And then Synergy data is in the dark blue. And you can see here the trend after 1 year is pamrevlumab actually way better than all this natural history data. And the same here for the after 2 years. Only as I mentioned earlier, only Synergy data is available. So we compare it against Synergy with matched population. And you can see that the trend after 2 years is in favor of pamrevlumab. Next slides. All right, so that's peak expiratory flow. The same thing as the pamrevlumab is the blue color, and Ricotti is in green. Gray is the Mayer placebo, and burgundy is Mayer in glucocorticoids. And you can see that pamrevlumab shown less decline in peak expiratory flow compared to all these papers. In 2 years data showing here in this diagram. Next slides. And this is the forced expiratory volume at 1 second. Also the same thing. Pamrevlumab is in blue, gray is Mayer, both arms, placebo and corticosteroids, and then the 2 years. And you can see here almost 50% better than Mayer paper and after 1 year. And this is the data for 2 years. Next. All right, so cardiac. So we'll talk about pulmonary, we'll talk about muscle. Let's talk about cardiac here. So next, what I meant by cardiac ejection fraction by MRI and cardiac fibrosis and myocardial circumferential strain. So cardiac MRI was used, as I mentioned, to evaluate the ejection fraction and also the cardiac fibrosis. We compared it against McDonald paper, actually, which is 2018 paper. The mean ages were similar. All patients were in steroid. The baseline of ejection fraction was not provided at McDonald paper. The decrease, there was a decrease of ejection fraction almost by 1% per year expected in this patient population based on the publication. In comparison to our study 079, at 1 year, cardiac function results showed a similar decline, a smaller decline in the mean ejection fraction with pamrevlumab compared to the natural history data, was almost 0.02 versus 0.82 in McDonald paper. So next slide shows that diagram. Will illustrate that here. As you can see here, the green one is natural history Synergy McDonald, sorry, not Synergy, the natural history McDonald paper, and that blue is the pamrevlumab arm, and you can see that the cardiac function is kind of stable here versus declined in McDonald, despite the fact there is a confidence interval, big confidence interval here. We have to keep it in mind, but in general, it's promising. Next slides. And also ejection fraction by MRI was not enough for us. So we looked also at the myocardial circumferential strain, which is more robust tool to evaluate the ejection itself of the power of the muscle of the left ventricle to eject during the ejection fraction. So as you can see here, we compared it against Hagen-Busch paper, and you can see here the myocardial circumferential strain slightly better than Hagen-Busch paper with regard to the global circumferential strain. So it's kind of stable. We stabilize the circumferential strain somehow. Next slides. And this is a correlation between the cardiac fibrosis in 1 year, after 1 year. Again, I didn't mention in the previous slide that there was, because of COVID, a bunch of patients did not make it to the MRI facilities because the unit was closed and all that. So so this is a correlation after 1 year. You can see that less cardiac fibrosis showed better ejection fraction. And that's the correlation that we had it since after 1 year of pamrevlumab. Next slides. and just 4 patients, as in the slides here, just 4 patients who did at 2 years, who completed the MRI. The rest of the patient, because of COVID, did not make it. Next. Oh, safety. All right, so 6 subjects withdrew consent because of the travel burden, mainly and the study fatigue in general. Because the infusion was bi-weekly, so they were tired after 2 years. Treatment emergent adverse events were mild to moderate in severity, 1 to 4 grade. 97% of the patient had treatment emergent adverse event throughout the trials. The most common adverse event, as any monoclonal actually, headache, migraine, nasopharyngitis, pyrexia, and fever, cough, and nausea and vomiting. 8 subjects had serious adverse event since the initiation of the phase 2 trial. No serious adverse events were deemed related to pamrevlumab by the PI, and none of any of these adverse events led to discontinuation of pamrevlumab. Overall vital sign, temperature, blood pressure, respiratory rate, heart rate, all were within accepted range throughout the trial. No QTc-B or C, QTc-B or F prolongation more than 480 millisecond noticed in these trials. And the bunch of lab were almost within accepted range for this population. Albumin, ALK-Phos, LFTs, transaminases, total belly, and so forth. So there was no surprises whatsoever in safety. Next slide. All right, take-home message. So pamrevlumab is an antibody against CTGF, which is a connective tissue growth factor. CTGF is a protein that plays a key role in fibrosis. Although several potential gene therapies are being investigated, DMD is currently managed through asymptomatic therapy, and there is nothing to cure this disease so far. Pamrevlumab has a potential to bring additional benefits for this DMD population. Pulmonary function is an important aspect for this patient, and most common cause of morbidity and mortality for these populations. In addition to cardiac dysfunction, also most leading cause of mortality for DMD patients. So preserving the muscle function, especially the upper arm, also is an important aspect here for these patients, especially for non-ambulatory patients, at least give them the function independency. So as you can see here, as I showed you earlier, the result from phase 2 in non-ambulatory subject should slow that pamrevlumab may slow down the disease progression. Pamrevlumab has been well tolerated in this pediatric population, and may provide additional benefits for these DMD patients compared to the published natural history data that we showed you. Pamrevlumab can also potentially be used in a broad range of patients, regardless of their specific gene mutation. So all these patients, all comers, there is no specific gene mutations to exclude any patients in our trials. Phase 3 Lelantos trials evaluating or confirming the efficacy and safety of pamrevlumab are ongoing. Next slide. And then I'll conclude my presentation here by saying my pamrevlumab mechanism of action may mitigate fibrosis in non-ambulatory patients, irrespective of their gene mutation. And this is, to our knowledge, this is the first anti-fibrotic agent that's shown a potential to slow down disease progression in this patient population. Again, thank you on behalf of FibroGen to PPMD community and to the audience, and we're delighted to be invited through PPMD conference. And again, this is just my name and my team, the great team that I have actually, and the email that here you can, if you feel that you have a patient eligible for our phase 3 trial, feel free to email us or call me directly in my cell. Thank you.
Thank you, Dr. Al-Mankabadi, and thank you for sharing your data with us here at conference. We know it's a small study population, but we're always excited to see positive trends, even as as you mentioned, comparing these 2 natural history studies. And of course, we look forward to seeing your, placebo-controlled trials. And as a reminder for those at home, if they are interested, those phase 3 is there's both a non-ambulatory and an ambulatory trial.
So Bassem, I have one last question before we sign off. So we saw the promising trends in the PUL data, the performance of upper limb. I think it's sometimes hard to interpret a few point change in measures like that. Are you thinking about, or have you measured patient-reported outcomes like the PUL PROM? That's a patient-reported outcome that's connected to the PUL. And if not, are you thinking about that in your phase 3 so that regulators can better understand as well what's the meaningfulness to a patient for a two-point change or a 3-point change on a measure like that?
That's a great question. Yes, we are thinking to implement this during the phase 3. However, we have the video tools through Casimir. So we elected to go with the video recording, which shows any changes in the performance of the upper limb, or not like specifically the performance, the patient reported outcome through a video recording. Definitely, this is something to explore further. But for now, for the phase 3, is the video is the main tool for the for the patient-reported outcome for now through Casimir as an exploratory endpoint.
Wonderful. Yeah, we're very supportive of Casimir, so we're grateful that you're doing these type of measures. So thank you so much for your time tonight.
Thank you.